Great, wonderful. So let's start and discuss the Oman Viva case. So let me start with Dr. Fatima. You just try to understand this scenario and get me the answer. 45
Okay.
years female came to the clinic for breast cancer chemotherapy in a daycare unit. She is vitally stable on daycare admission and asymptomatic at the time of admission. The vitals are stable on admission. She started on the first dose of paclitaxel chemotherapy for the breast cancer. After 1 minute of chemotherapy with paclitaxel, she is complaining of generalized urticaria, difficulty in breathing, lightheadedness, heaviness in the chest. On examination, temperature 98 Fahrenheit, pulse rate is 100, blood pressure is 90/60. RS respiratory system shows bronchospasm, respiratory rate is 30, and SpO2 of 88% on the room air. CNS, she looks to be little confused but conscious and well oriented. So, how you will manage this patient? What is your diagnosis?
It is a case of anaphylactic reaction, sir, due to chemotherapy drug.
Okay, great. So, anaphylactic reaction. So, is it anaphylactic reaction or anaphylactic shock?
Yes, sir, shock. She is in shock.
Fair enough. So, this is anaphylactic shock, right? So, anaphylactic shock. So, can you define what is the difference between allergy, simple allergy, and anaphylactic shock? Is there any difference between allergy and anaphylactic shock? Why it is not allergy?
Allergy, the reaction will be less, sir.
Okay,
Systemic reaction less, like the BP and pulse rate will be normal. They will be
fair enough.
only having a skin reaction
Okay,
mostly.
fair enough.
In
Fair enough. Fair enough. So this patient by you, it looks like anaphylactic shock. So how you supposed to manage this patient? That is the second. So you make some diagnosis that okay, fine, this is patient has anaphylactic shock. So the next question is how will you manage this patient? What you start? How you start? What's your stepwise approach to management of this patient? Yes, go ahead.
we have to start with the airway breathing circulation.
Okay,
We
wonderful.
have to
So airway breathing circulation. So A for airway, B for breathing, and C for circulation. Okay, fine. What else you want to do?
we have to give supplementary oxygen because SpO2 is less than 92.
Okay, so oxygen, wonderful. So you want to give the oxygen to the patients because it looks like a hypoxia, right? So less than 92 or so. So you supplemented the oxygens as well. What else or what next you want to do?
Mm. First, we have to give adrenaline, sir.
Adrenaline you have to give. Adrenaline. What dose? Three things I want to know. What dose you will use, what route you use, right? And how sub-Q, IV or IM you want to give. Three questions I want to know from you. Yes, please. You can
Zero
start.
point 0.5 ml IM.
0.5 mg, that is the dose. The route is intramuscular. Okay. And what's the dilution? If I can ask you, what is the dilution?
1 in 1000, sir. 1 is to 1000.
1 into 1,000. Fair enough. So how this adrenaline will going to help in this patient? Yes, Dr. Salika, let me come to you now. So how the adrenaline will going to help in this patient? Why you want to give the adrenaline? Why you can't give the salbutamol for bronchospasm? What is
Um,
the mechanism of action of adrenaline? How it acts in the case
the
of anaphylactic shock?
adrenaline acts on adrenergic nerve endings, everywhere in the heart, in the blood vessels, in the bronchioles, everywhere. Adrenergic nerve is there. So
Mhm.
the
So it acts on what? Alpha
mechanism
1, alpha 2, beta
alpha
1,
2,
and beta 2.
beta 1, beta 2, and also JG cells of kidney as a beta 1. Everywhere adrenaline N receptor is there, it will act and will stimulate the heart and relieves bronchospasm, improves the BP.
Mhm. Why? So why you cannot use the noradrenaline? Why you want to use the adrenaline? Why not the noradrenaline? That also increases the blood pressure.
Mm,
It's a
yes.
strong. It is noradrenaline is even stronger than adrenaline for increasing the blood pressure. Why you don't want to use the noradrenaline?
Mm. Noradrenaline we used to give in infusion usually.
Sorry, I think your voice is
Uh,
little blurring. Sorry, can you make
okay,
your mic little closer? What you are saying?
yes. Noradrenaline, no, we used to give in infusion form.
Mhm.
Uh,
But what is the difference? I mean, why? My question is why you cannot use the noradrenaline? Why you want to use the adrenaline only? Both can increase the blood pressure, and I'll show you the data. Noradrenaline is more potent and stronger than adrenaline for blood pressure. Then why you want to? Do you know the head-to-head comparison, Dr. Fatima, for noradrenaline and adrenaline?
No, sir.
Yes or no?
No, sir.
no, sir,
Wonderful.
no.
I will I will clarify everything. Don't worry. So now let's jump to the case, right? So this is a case summary, right? This is a case. This is a summary of the case, right? So case summary is that this timing is extremely important, right? While you are answering anything as anaphylaxis, so symptoms occur within minute of paclitaxel for the breast cancer, highly suggestive of severe hypersensitivity or anaphylaxis. Symptoms in our case is urticaria, yes, dyspnea, chest heaviness, yes, and lightheadedness. So all are there. What is the blood pressure? 90 over 60, so hypotension. Tachypnea, respiratory rate 30, right? Bronchospasm and SpO2, right? So these are the classical patient, classical presentation, classical symptoms, classical signs. So this is an anaphylactic shock. Why word use shock? Anything less than 90 blood pressure is shock, right? Due to paclitaxel, which is the use for the breast cancer treatment. So you need to interpret each and every MCQ, or you need to interpret all the scenarios whatever they had given to you. You need to make some conclusion by things. What is the age? What happens to paclitaxel? Paclitaxel given for what? After giving paclitaxel, what happens? What's the time frame? Right, what exactly the system involved, where is this, what are the signs and symptoms. By this, I mean, it applies to the same, right? If I can give you the chest pain scenario, you need to interpret in same way, right? So you both did the good job, right? So this is one things we got to know, that this patient is anaphylactic shock secondary to the paclitaxel, which was given for the breast cancer. As you know, the baseline, everything is normal, baseline vitals are normal, oxygen is normal, everything is normal, but after starting this drug, right, this is the picture. So this is extremely important, that anaphylaxis, right, usually happens due to the exposure of some allergens, like some chemotherapeutic agents, sulfur drug, some kind of antibiotic, X, food, right? So these are the some triggers, right? So here the trigger is paclitaxel, right, which makes the anaphylaxis, right? So there must be some kind of trigger in anaphylaxis. It could be food, it could be some agent, it could be drug, it could be IV drug, it could be antibiotic, it could be sulfur, it could be chemotherapy. Is that clear to you? Yes or no? So this is very important. Even
Yes.
with the history, you can get to know. Okay. So what is the most important thing? How to manage this patient, right? Stepwise Viva management. So first you miss this, both of you miss this, immediately stop the paclitaxel. extremely important immediately, because this is the culprit, right? When you are giving this drug, so you are doing the airway breathing circulation, but you are not stopping the paclitaxel. So anaphylaxis will keep coming and keep worsening the condition. Are you getting me? Yes or no? Right?
Yes,
So
sir.
whenever
Yes, sir.
any
Yes.
yes, whenever any exposure or any culprit here, the number one culprit for anaphylaxis is paclitaxel. So you have to stop, you which you started 1 or 2 minutes back. First you have to stop, right? And then call anyone wherever you want to call. First stop it and then call. First stop it and then call. Is that clear? Right?
Yes.
So immediately stop the paclitaxel in infusion or levofloxacin infusion or some IV drug which you are giving and you are suspecting this is culprit. So whatever the culprit, you stop it. Stop the culprit. That's it. Here it's paclitaxel. Right? Keep the IV line open with normal saline. Right? So this is first step. Stop it. Then you can start ABC. Obviously, it comes in any emergency. Right? So airway breathing circulation. But this is first thing. Second thing is call for the help. Activate the emergency team, right? Because sometimes what happens, you cannot manage alone patients, right? Because if this patient collapse, say for example collapse, patient becomes pulseless, BP-less. Now the ACLS will start, right? Because patient is pulseless, patient is BP-less, patient is unconscious. What you do, right? So you need to ask for the help. You need to call for the defibrillator. You need to call for various people to do the CPR and defibrillation, CPR, defibrillation, epinephrine. Lot of juggling is going on, right? So you need to first stop the culprit. Number one, you cannot miss it. Second thing is you need to activate the emergency services, and after that whatever you want to do, the same way ABC, right? So A means airway. Assess the airway patency. Assess the airway patency. Right. So how you assess the airway? Right. You need to look sometimes. Right. Assess the airway pattern, whether airway is patent or not. Right. Patent means it's open or not. If not, you can put some this oral airways just to make it patent. Right. Patent. And prepare for the airway support if the stridor or worsening of the mental status, right? So you need to ready yourself that if something goes wrong, airway is compromised, you will do immediately. You do the intubate the patient, right? When significant hypoxia or patient mental status is altered because of hypoxia, right? So airway, I can say secure the airway and maintain the airway. Two word important: secure and maintain. So first you secure the airway, you maintain the airway, right? Second thing is breathing, right? So breathing, so give 100% oxygen via nasal rebreathe mask, right? Which can give up to 10 to 15 liter per minute high flow oxygen. So give 100% oxygen via non-rebreathe mask, right? And sit patients upright unless hypotensive, right? So that is also important clinical tip. Circulation, start rapid IV fluid, or you can say bolus. Bolus. What do you mean by bolus? By giving the large amount of this fluid, 500 to 1000 or 1 liter fluid in just 30 minutes, in just 30 minutes or as fast as possible. So if one side upper limb vein is not enough, take vein IV line at the both upper limb, right? Take the both IV line at the both upper limb, right? So you can start as fast as possible, right? Because patient is in hypotension, our blood pressure is 90, right? So you want to increase from 90 to 120 or 120 plus, right? So first and foremost is to push the IV fluid or give the bolus 500 to 1000 or 1000 or up to 2 liters you can give if the cardiac functions are okay in general, right? So repeat until BP improves. See the repeat until BP improves. So at least 1 to 2 liters of IV fast bolus you can give it to the patient, right? So now it's all steps are clear. Once you diagnose it is anaphylaxis, stop the culprit, ask for the help, do the ABC, right? These are the basic thing. And last but not the least, most important, the immediate next step in the management is to administer the adrenaline. Adrenaline is equal to epinephrine. Adrenaline is equal to epinephrine. Don't get confused in the exam, right? And noradrenaline is equal to norepinephrine. It is the only life-saving drug, right, for the adrenaline. Nothing comes before the adrenaline, right? No other things, no, right? No bronchodilator, no nothing. Adrenaline top the list of the drug, right? After stopping the culprit, ask for the help. This is second step. and third step is ABC, right? These are the common step for every most of the emergency, right? And then the first immediate step is the adrenaline. Adrenaline, I am not the intravascular, right? So it's very important. You tell me later on the reason for IM. Why not IV? Why not IV? Go and find out. So IM dose, first line treatment, adrenaline 0.5 milligram, intramuscular 1s 1000 dilution into the lateral wall of thigh. So four things, five things. Which drug? Adrenaline. What is the dose? 0.5 milligram. What is the route? Intramuscular. What is the dilution? 1s 1000. And what is the site? It is lateral wall of thigh. Is that clear? We need to mug up all five things. Adrenaline, intramuscular, right? Adrenaline 0.5 milligram, intramuscular, 1s 1000 dilution, anterolateral wall of thigh or lateral wall of thigh. Is that clear? If this does not improve the condition like cardiovascular system and respiratory system is right. So bronchospasm is not improved. Hypoxia is not improved. Respiratory rate is not improved. Hypotension is not improved. Right? In that case, repeat every 5 minutes if no improvement. Repeat every 5 minutes, no improvement. Can you tell me, Dr. Salika, how many injections you can give? Say, for example, you had given one dose, right? After 5 minutes, no improvement. Second dose. After 5 minutes, no improvement. Third dose. How many doses you can give it to this patient? Any idea?
Three doses, sir.
Sorry?
Three, three doses, sir.
How many doses? That is what I'm asking you. How many maximum dose? Three
Three.
dose, 5 dose, 6 dose? How many dose you can give to this patient? Because you are, I'm saying you the repeat every 5 minutes if no improvement. So if the patient has no improvement after 0.5 milligram of intramuscular injections on lateral thigh, same recommended dose I'd given 5 minutes, no improvement. Again, after 5 minutes, no improvement. How long give 3 dose, 5 dose, 10 dose, 20 dose, 25 dose of adrenaline? How much you give? Are you getting my question? Yes or
Three
no?
doses, sir. Yes, sir. Yes.
Sir, yes, Fatima. What do you think? How many doses you can give it?
Actually, I'm not sure. 3 to 5 dose, I
Fair
guess.
enough. So there is no 3 dose, no 5 dose, no 10 dose. As far as you can give, you give it. It's a life-saving condition. Otherwise, patient will die. Don't worry about side
Oh,
effect. Give as much as
okay.
possible.
Okay, sir.
Got it?
Yes, sir. Sir, is my
Right.
voice audible? Am I audible, sir?
Yes, yes, you are audible now. You are
Okay.
audible.
Thank
Yes. So if the patient deteriorates or cardiac arrest, right, risk, prepare IV adrenaline infusion in ICU setting, right? So this is the second, but first is the intramuscular dose is the first line treatment for this patient. This is the five things you need to remember and repeat at five. Repeat at 5 minutes if no improvement. Maximum dose you can give it to the patient. You have no other options, right? You did it the best. There is no drug beyond adrenaline, right? So now let me give you a little more clarity adrenaline versus noradrenaline, which is also very, very important in clinical this vignity. So I would like to give you the clear idea about adrenaline versus noradrenaline. So one second, let me find out this slides for you, right? So this is ABC. You start this, right? After that, we'll continue, right? So basic difference here, adrenaline, adrenaline or epinephrine or noradrenaline is equal to norepinephrine, right? So classification endogenous catecholamines. This is also endogenous catecholamines, right? Main role of adrenaline, fight to flight hormone, life saving in anaphylaxis, powerful vasoconstrictions, maintain the BP, release from adrenal medulla, sympathetic nerve ending and adrenal medulla. So there are two sides, sympathetic nerve ending as well as right as well as adrenal medulla. So this is the little things. Let me go little more to the pharmacology, exactly where and how they act, that brings complete clarity to you for many questions. So receptor action most important for exam adrenaline, and this is noradrenaline. What we are talking about adrenaline or epinephrine? Noradrenaline is equal to norepinephrine. Is that clear to you? Yes or no? At least tell me yes or no. Right? So adrenaline has a strong alpha 1 right activity, moderate alpha 2 activity, strong beta 1 activity, and strong bronchodilation or bronchial smooth muscle activity and B3 activity. Here if you can see the right, so alpha 1 alpha 2 major and beta 1 beta 2, right? So this is what the thing is. So what happens in the anaphylaxis? Let's just little see anaphylaxis. So in anaphylaxis, because of paclitaxel or culprit, it acts on the skin and mucous membrane. Skin and mucous membrane, number one. Then respiratory system and cardiovascular system. Right. So in skin and mucous membrane, what happens? There is a edema or swollen face, tongue, laryngeal or angioedema, right? This is the things. In respiratory system, first of all, bronchospasm, right? Second thing is hypoxia. Third thing is increased respiratory rate. Cardiovascular system, fall the blood pressure. Now, this is the pathology, Dr. Salika. This is the pathology of anaphylaxis. You want to reverse everything. You want to reverse everything. And this is the only drug which can reverse the everything. Alpha 1 activity is strong, right? So what alpha 1 activity cause? It cause vasoconstriction, increased blood pressure. So this effect will be taken care by alpha 1, right? Alpha 2 moderate, beta 1 strong. So beta 1 is also situated on the heart, right? So beta 1. So it increases the force of contraction, it increases the cardiac output. So blood pressure is increased by the heart as well as the periphery. And there is a lots of this respiratory things, right? And this respiratory things can be taken care by beta 2. Beta 2. It situated in the bronchial smooth muscle, right? This is trachea, right? This is bronchial rings, and there is a bronchial smooth muscle which responsible for constriction and dilatation, right? So it's situated here, so it dilates, so it helps in the respiratory, it helps in the cardiovascular system, right? And it also by doing the vasoconstriction, it can help in the laryngeal edema as well, angioedema as well. So this is the drug of choice for anaphylaxis. Why not noradrenaline? Why not noradrenaline? Because noradrenaline is very strong or dominant actions mainly on the alpha 1, mainly on the alpha 1. So this is help in the uh, increasing the blood pressure, but it has not very good activity here. It is not very good activity here, right? So this alone is not a good drug to control the anaphylaxis, right? So this is why. So we will see this later on, right? Where to use adrenaline, where to use the noradrenaline in the same class, right? So this is the general mechanism for you to understand. Beta 1 and beta 2 activities see minimal. Beta 2 is minimal, so it won't help in the respiratory rate, bronchospasm, improving the things. So adrenaline means add both alpha and beta, especially beta 2, right? Noradrenaline, alpha mainly, some beta. It's a reverse, right? So adrenaline means remember add alpha plus beta, but beta 2 mainly. Here noradrenaline only alpha mainly, some beta or minimal beta, right? So if someone asks you in your exam that oh how they act or how do they suppose they act, right? So this is what the thing is, right? We need to see the physiology as well, right? So what is the physiology, right, which we need to understand, right, rather than mug up? So adrenaline, as we seen, it increases the heart rate, so our action is done because hypotension, right? So it increases the heart rate via beta 1. So it increases the blood pressure, it increases the heart rate. How they increase the heart rate? Cardiac output is increased, right? Systemic vascular resistance, mild increase, right? Because alpha activity here, the large or the stronger alpha 1 activity. Bronchospasm, yes, it is right because it is situated in the bronchial smooth muscle. Here there is noradrenaline, no things, right? So it's not much helpful because our things, anaphylaxis includes respiratory and cardiac both. So you need to take care of both. BP pact increased systolic blood pressure and diastolic could be normal. Increases both systolic and diastolic. Extremely important, right? So whenever you want to increase the systolic and diastolic blood pressure, like 90 by 50 patient comes to you in the emergency room, are you going to use the adrenaline or noradrenaline? The answer is noradrenaline because it has increased both systolic and diastolic blood pressure, right? Very important, right? And skin perfusion, it reduced drastically. So this is what the physiological effect of adrenaline and noradrenaline, which we need to know, right? It is very important, right? So here now the clinical use, right? Clinical use. So clinical use adrenaline, right? So it has adrenaline in both alpha and beta, and in beta, right? It it is beta 1 plus beta 2 more adrenaline. So beta 2, beta 1 plus alpha effect useful. Anaphylaxis first line treatment, right? Because it do acts on the heart, it acts on the smooth muscle, it acts on the peripheral blood vessel, increase the peripheral vascular resistance, and increases the blood pressure. So anaphylaxis is first line, not the noradrenaline, adrenaline. Sorry, I'll just make your mic muted. There's a lot of noise background, so I muted. Right. So anaphylaxis first line, cardiac arrest, yes, advanced cardiac life support, the things is used. Severe asthma, yes, why? Because it has a beta 2 agonist, strong agonist. Local anesthetic, right? Because it causes the vasoconstriction. So many a times xylocaine is added with the adrenaline or epinephrine. Why? Because it has a local anesthetic effect with the vasoconstriction, so it reduces the bleeding to the patients at the local site. So many a times when somebody has a wound or there is a bleeding and they wants to take a stitch, they are using both the things, xylocline plus adrenaline. So xylocline is local anesthesia, adrenaline do the vasoconstriction and reduce the bleeding, right? And septic shock if refractory to noradrenaline. So in noradrenaline, right, it is a first line treatment for this. So this is used only, it's extremely important, only if the refractory to noradrenaline. So you had given the noradrenaline, if it does not acts, then and then you use it, but first line is this. While noradrenaline, first line drug for the septic shock, right? Not for the anaphylaxis, not for the anaphylaxis. Anaphylaxis, first line epinephrine. Neurogenic shock, yes. And a profound hypotension with vasodilator collapse and cardiogenic shock, right? So noradrenaline in general, right, can be used as a drug of choice when you want to increase the both systolic and diastolic blood pressure, septic shock, cardiogenic shock, neurogenic shock. So this is septic shock comes, neurogenic shock comes, right? Cardiogenic shock comes. So noradrenaline can be used in all most of the shocks, right? So this is what the basic thing is also. Another thing is let me discuss is the side effect. So what are the side effect of this drug? So adrenaline, as we saw, increases the heart rate. So tachycardia would be there, hypertension could be there, hyperglycemia could be there, increase the movement or tremor is there, and ventricular arrhythmia is there. So everything is increased here, right? Tachycardia here, not much tachycardia, severe vasoconstrictions, peripheral ischemia. Peripheral ischemia is because of the vasoconstriction likely. Reflex bradycardia, tissue necrosis if extravasated, and arrhythmia is also possible. Right? So these are the basic some side effects. So when you are using this drug, right, then you need to keep these side effects in your mind, right? So what is the bottom line? So what is the bottom line? So from where we started our talk, right? Where we started our talk, let's go back to the basic, right? So this is a case. Let's do the summarize the whole case shortly, right? So this is the summarization of our case, right? So this is anaphylactic shock. You stop the drug or culprit, ask for the help, do the ABC, use the epinephrine. We now know the dose, right? Apart from the epinephrine, apart from the adrenaline, what else you can use and how they help? So after adrenaline, you cannot bypass the adrenaline. Adrenaline is a life-saving drug. Are you getting me, both of you? Yes or no? So
Yes,
adrenaline
sir.
is a drug of
Yes,
choice,
sir.
right? After that, H1 antihistamine, right? Chlorpheniramine maleate 10 milligram IV or diphenhydramine can be used, right? So anaphylaxis can happen. Anaphylaxis happen, right? Because of histamine. So histamine release from the mast cell. The name of the cell is mast cell. Release the histamine, and this histamine does the profound hypotension, vasodilatation, and profound hypotension. Right. So if you want to you want to stop this histamine to release, right? So antihistamine you have to give. So right. So H1 and H2 both blockers. So H1 name is chlorpheniramine maleate. H2 is ranitidine. Right, it is optional but commonly can be used. So mainly the H1. Corticosteroid, hydrocortisone 200 milligram or methylprednisolone 125 milligram prevents the biphasic reaction, slower onset. So this is not a drug of choice in emergency. The biggest reason is slower, right? The biggest reason is slower onset of steroid. So when anaphylaxis patient is coming, if you give routinely in India, people give Avil and Dexona, right? Chlorpheniramine maleate and Dexona, right? So they are mainly for the prevention, not for the acute treatment. It will not open up the airway. It will not increase the BP. It will not increase the cardiac output. Are you getting me? Yes or no? Right? So this is by and
Yes,
large
sir.
is mainly important in the prevention rather than the treatment. But this other drug is very important. So after giving the adrenaline, you need to give chlorpheniramine maleate and corticosteroid mainly for the prevention. Bronchospasm management, bronchospasm, adrenaline itself is a bronchodilator, beta 2 strong effect on this, but you can use the salbutamol nebulization additional and add the ipratropium if needed. Ipratropium bromide is an anticholinergic drug, right, which reduces the secretion. So ipratropium bromide and salbutamol both can be used, right? One reduces the secretions in the respiratory and another dilates the bronchus, right? So these are the drug. What you need to monitor, continuous monitoring is required, especially the vitals, right? So you need to check on every 2 to 5 minutes whether it is responding or not. If not responding, epinephrine. After 5 minutes, if not responding, epinephrine. Not responding, epinephrine. So every 2 to 5 minutes, you need a blood pressure, heart rate, respiratory, oxygen, or in short, you can say the vitals, right? In short, you need to monitor the vitals. If not improving, you need to consider the repeat dose. If hypertension persists after even epinephrine, what you can do? Give additional fluid bolus, right? 1 to 2 liters of fluid bolus you can give and start vasopressor infusion or noradrenaline in ICU, right? So if hypotension is persistent, you had to give an epinephrine. There is no improvement. Patient is not much improving. Still, everything is improved well, but still not improved. Then who is the most game changer for blood pressure is noradrenaline. Strong, potent alpha activity, which increases the peripheral vascular resistance, increase the blood pressure, right? So it's extremely important, but when it is used not in the routine case, if hypotension persistent or refractory hypotension, even after giving the epinephrine, it is not improving, in that case you can give it. Observe the patient minimum 6 hours for reactions, 24 hours for severe reactions. So if some patient has a severe reactions, severe hypotension, very bad condition, even after reversal of this, you need to monitor this patient and document and report as well. So how you conclude, right? So and future management, avoid the paclitaxel, right, until reviewed by oncologist, or you can give the desensitized protocol is also there, right? So we'll discuss sometimes later on what is that. So what is the 30-second exam answer, the perfect for Viva? So you can answer in this way. This is what the uh, whole this 30 second will decide you how you responded through this MCQ. So this patient developed a acute anaphylactic reaction to the paclitaxel. I will immediately stop the infusion. I ask for the help. Two step is done. Stop the infusion, ask for the help. Are you getting me, Salika? Yes or no? So this patient
Yes,
developed
sir.
an acute anaphylactic reactions to paclitaxel. I will immediately stop the infusion and call for the help. I'll give you ABC, 100% oxygen, and I'll start IV fluid. I'll administer five things: adrenaline, intramuscular 0.5 ml immediately, and repeat if needed every 5 minutes. I'll also give the hydrocortisone H1 blocker antihistamine salbutamol bronchodilator for the bronchospasm. I will monitor the patients very closely and monitor the vitals every 2 to 5 minutes. Manage persistent hypotension with the vasopressor or noradrenaline, and I'll observe the patient for few hours. This reaction will be documented, and future paclitaxel dosing should be considered via desensitization. Is everything covered, Dr. Fatima?
Yes, sir.
Salika,
Yes, sir.
is everything covered?
Yes, sir.
Your voice is low. Fine.
Yes,
So
sir.
this is
Am
what.
I audible now? Okay.
Yes, yes, audible. Keep your mic little closer, I guess. So this is what we already seen it,
Okay.
right? So this is also we have seen it. So this is also we have seen it. The side effect we also seen it. So this is little practical point before ending the session. So Viva friendly memory trick. Adrenaline means A means all receptor, alpha and beta. Noradrenaline means narrow vessels, N for narrow vessels means alpha 1, right? So this is a technique to remember. Adrenaline, all alpha and beta, noradrenaline, N for narrow vessels, so alpha 1 mainly. When to use which, this is extremely important. I took lots of times in my residency to understand all this, but this is absolutely, if you understand it very, you can manage hundreds of patients in the ICU with the one slide. So when you have when to use which, when to use which means at what condition you use which drug, that is the meaning of this word, when to use which, right? So if you have anaphylaxis means which, right? In anaphylaxis is the condition. What to use? Adrenaline. Why? Bronchodilation, increase blood pressure, reverse the airway edema. Is that clear? So whenever there is an anaphylaxis, the first drug or first line treatment of choice is adrenaline. What if there is a septic shock with hypotension? Septic shock with hypotension. Noradrenaline. Reason: strong alpha 1 vasoconstrictions restore the systemic vascular resistance. Extremely important. So when patient has a pneumonia, patient comes to you with a pneumonia, curve 65 is very bad. You admitted into the ICU, patient now going into the septicemic shock, right? At that time, you don't need to use the adrenaline. Use the noradrenaline. Why? It is alpha 1 strong act, right? Especially when blood pressure is 80 over 40, right? When you want to increase the systolic as well as diastolic blood pressure, right? Strong 1 alpha constrictions activity, so use noradrenaline. Third, cardiac arrest, use the adrenaline. Cardiac arrest, 1 milligram every 3 to 5 minutes. Cardiac arrest, where you need the increased force of contraction, increase the heart rate, increase the cardiac output, increase the blood pressure, right? Everything can be achieved here, right? So bronchospasm or asthma attack. Bronchospasm or asthma attack. Simple and sober. Use the adrenaline because it has potent beta 2 bronchodilate activity, not the norepinephrine. So it is used. And hypotension due to vasodilatation or spinal anesthesia, noradrenaline. So nutshell, whenever your concentration is to increase the mainly the only blood pressure, use the noradrenaline. Use the noradrenaline. Is that clear to everyone? Yes or no?
Yes,
Sir.
sir.
right? So this is looks little simple, but it is so high yield points which will help you a lot. So last but not the least, before closing the session, management of difference most important in exam, right? So how you do the difference? So before that, let me clarify you the difference, exactly the head to head difference between allergy, mild to moderate allergy, severe allergy. So mild to moderate versus severe allergy. Severe allergy is basically anaphylaxis, right? So this is allergy, and if it is worsen, it will go to anaphylaxis. So basically, the anaphylaxis is the most bad version of allergy is anaphylaxis. Is that clear? Yes or no? Yes or no?
Yes,
Right?
sir.
So
Yes,
mild
sir.
because mechanism is same, right? But severe form means there is an involvement of two things: respiratory, cardiovascular, neurological system. When involved, it is anaphylaxis, which is usually not involved. Usually not involved. So here, swelling of the face and eyes. Simple swelling of the face and eyes, tingling in the mouth and swelling of the lips, right? Hives or heads, right? So anywhere on the hives on the body, stomach pain, vomiting. See here, no respiratory system involved, no cardiovascular involved, no CNS involved. So it's a simple mild form, right? So if you had some injection and you have urticaria, it's a mild allergy, right? If you have a sulfar drug and you have a lot of rash on your skin, it is the allergy, not the anaphylaxis. What is anaphylaxis? Severe form. Persistent dizziness, collapse, pale, swelling of the tongue, difficulty in breathing or noise or bronchospasm, swelling and tightness in the throat, that is laryngeal edema, right? And along with that, you have hypotension, so it is anaphylaxis. And when the hypotension add to this or low blood pressure add to this, it is called as the anaphylactic shock. Is that clear? Yes or no? Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. And this is the schematic presentation of anaphylaxis. So what happens? The crux, right? The conclusion of our whole talk is the anaphylactic reactions. Whenever you feel it is because of the food, it is because of the drug, it is because of any kind of the this allergens or exposures, right? Anaphylaxis reactions happens. First and foremost step, as you stop the drug, right? If you giving the IV, ask for the help, and then airway, breathing, circulation, disability, and exposure. Remove the client from the exposure, right? So it is diagnostic look for acute onset, life-threatening airway and breathing circulation problem, right? And usually skin and mucous membrane changes, as I told you, right? So on the suspicious of anaphylaxis, call for the help, right? Patient make comfortable or raise the leg to increase the blood pressure. So this is basic thing. And first drug comes in the picture in anaphylactic shock is the epinephrine or adrenaline. 0.5 revisions I am doing it, 0.5 milligram. Third thing is intramuscular dilution is 1s 1000, and lateral wall of thigh. Five things: adrenaline 0.5, intramuscular dilution, lateral wall of thigh. That's it. So you need to give it. And other drugs you can give along with this is H1 blocker, chlorpheniramine maleate, right? And another is steroid can also be used, right, for these patients for mainly the prevention. Why it is not a good drug? Because it is not fast acting, it's a slow acting, so it's not in the treatment algorithm, but it can be used along with. But you, this is the number one life saving drug, right? So establish the airway, high flow oxygen, IV fluid, ABC, chlorpheniramine maleate, and monitor the vitals, right? So this is what the schematic presentation of things, right? So before I end up my sessions here, I would like to give the final line of allergy versus anaphylaxis. Very important. People doesn't know the difference between allergy and anaphylaxis, but now onwards we never ever do the mistake, right? So allergy, this is allergy, and this is anaphylaxis. So allergy, it's in the minute to hours. Can you see? After 4 hours, 6 hours allergy. This is rapid onset within minute, within minute. So something happens within minute, the bed, right? It is most likely anaphylaxis. Skin, local or generalized urticaria. Here the diffuse urticaria. Angioedema, flushing is present. Respiratory system, mild cough, mild cough. Here the airway compromise, stridor, right? Wheezing, dyspnea, bronchospasm. So very severe this effect on the anaphylaxis is advanced, right? Very, very, very things, right? Cardiovascular system usually normal. Cardiovascular is usually normal here, right? So this is extremely important differentiating point. Cardiovascular system is usually normal in allergy. Respiratory, there is no much very thing except the cough, mild cough or itching. That's it. This is right, but no very bad hypoxia, respiratory rate, nothing is there, right? And here neurological is also normal. Neurological is normal in allergy, while there is a neurological symptoms are also there, including the confusions, right? Organ systems involved, right? Typically one, like skin or mucous membrane. Here skin involved, mucous membrane involved, cardiovascular involved, respiratory involved, right? So multiple systems can involved in anaphylaxis. Risk of life is very low, and here risk of life is very, very untreated, unproperly managed patient can die in front of you. And let me tell you last, this scenario is a real scenario in my hospital, right? Few years back we had the same patient and we lost that patient. Unfortunately, we lost the young lady. Very severe bad anaphylactic reaction to the same paclitaxel. I'm medical oncologist and hematologist, so we treat chemotherapy every day, and paclitaxel is one of the most highly used drug in the medical oncology globally. Lots of indication, lots of disease. It is used as a drug of choice, right? So it is nothing something unusual or thing. So this is extremely important, right? And last but not the least, right? Trigger example. So trigger, I told you already which are the trigger: food, drug, insect bite, environmental. Here same trigger, but reaction is systemic and severe. So triggers could be the same allergies, right? So say for example, sulfur drug, right? Sulfur drug can cause simple allergy as well, and it can cause fatal anaphylaxis as well. So trigger are the same, but the beauty is that systematic, right? Reaction is systematic, multiple system involved, and usually severe. So this is mild and moderate. This is a severe, right? And immediate treatment is antihistamine and steroid. Here the beauty is that there is no adrenaline, no adrenaline. Cardiac system is not involved. Respiratory system is not involved. Neurological system is not involved. It is usually localized, right? So use the antihistamine, right? H1 blocker, and use the steroid, right? So this is used only for the allergy, but when there is a anaphylaxis, right? Neither antihistamine nor steroid is used. First line treatment is IM adrenaline, right? Airway management, ABC. So little more aggressive and extremely important management we need to do. So that's all for our topics for today. So thank you very much for listening me coolly and calmly. I think I tried my level best to cover each and every point related with the anaphylaxis. So just summarize with this. This is the scenario, this is the diagnosis, how we approach this ABC, and then adrenaline. Then after adrenaline, what else can be offered to the patients, right? What we need to monitor, what if persistent hypotension in spite of adrenaline, you can use noradrenaline. Monitor the patients for 24 hours, right? And this is the answer. Difference between epinephrine, norepinephrine, how and where they exactly act. What are the side effects, how they use it, what are the side effects of this, and specific condition when to use which. We now also get to know the idea, right? And what is the difference between allergy and anaphylaxis? We have clarity, algorithm, we have idea, and how you head to head differentiate between the allergy and anaphylaxis. So that's all. Thank you very much. I think you got the idea. This is one of the most high yield questions in the exam. One of the most high yield questions in the exam, anaphylaxis. Every other student has been asked this question, And that is why I took little bit more in detail, right? If they ask you, oh, what is the difference between allergy and anaphylaxis? So I don't want you to be like just keep cool and calm and you don't know what is anaphylaxis, what is allergy. So our job is to give the and get the general idea about the whole condition. So whatever they ask, the small things, even you can answer very easily in the exam point of view, and that is why I little stretched this anaphylaxis. So before I end up my session, I would like to have quick feedback on this. How did you enjoy? What was the learning? What was the new learning? And what's the concept clarity and building in your both of your mind?
Excuse me, sir.
Very good. Excellent.
Excuse me, sir.
Sorry?
Sir, I have a doubt, sir.
Yes, please.
Uh, Sir, actually, when we have to switch from IM to IV, sir, adrenaline.
IM to IV you can use when IM is not effective and patient is going into the cardiac arrest.
Okay.
Right? So anaphylaxis does not mean cardiac arrest, right? It's a hypotension, it's a hypoxia, it's a tachypnea, but not the cardiac arrest. So when there's a cardiac arrest, you can use this.
Okay.
Like the
So
way you are
even if
using in
IV line
AC,
is there,
even you can use it in
sorry.
ACLS protocol, right? ACLS protocol, you know. So ACLS protocol, we don't give the intramuscular IV 1 milligram every 3 to 5 minutes, isn't it?
Yes, sir.
Yes. Yes, Salika.
Or what? Yes, sir. So even if we have IV access, because patient is on chemo, but still we should give IM only. Start with IM.
Yes.
Yes.
It can be used only
Okay,
in
sir.
cardiac arrest,
So
not in the
one more.
anaphylaxis.
Okay, sir. Normal. Okay. BP is there, everything is there. So we give start with IM.
Yes.
So one more doubt also. At
Yes,
what
please.
saturation, I mean, less than 92, we should start oxygen. Generally, as we know these things,
Usually 92 is
generally,
cutoff line. Yeah, so if anything less than 92 and clear cut is 90, clear cut is 90, less than 90 you must start it. But up to 92, that's fine. And let me tell you one more thing, they will not confuse you. Even if you start at 92, 93, that's fine. It will not going to harm much a
okay.
patient, is right?
Yes.
Especially if the patient is not very bad. I mean, uh, this COPD, very bad COPD, where giving excessive oxygen is a problem. But in general, right, if it is 92, you if you give the answer that okay, fine, I would like to supplement the oxygen, not a problem. But
Okay.
I mean,
Then
obviously,
sickle
beyond
cell case.
95, beyond
Oh,
95, 96, you don't need to give it, right? It's absolutely fine. So there is no advantage of adding the oxygen to the patient. You understand? When
okay.
already there is a tissue
Yes.
oxygenation is normal, what I mean advantage you add to the patients while adding the oxygen when it is already normal?
No.
Yes.
In sickle cell case, sir, sickle cell case also like 92, 90 only.
92, 92. But as I told you, they will not confuse in exam. They will not tell you 92 or
Okay.
91% what you start. But don't
Okay.
give above 95, clear cut. Don't give above 95.
Okay.
But between 90 to 95, if you can answer even that, oh, I would like to supplement the oxygen, that's fine. Don't worry. That's
Okay.
fine.
Okay, sir. Thank you so much, sir. Thank you.
Wonderful. So, how
Sir,
was your
one more doubt.
learning overall? Yes, 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 Fatima.
Um, is it okay to give IV adrenaline by a GP doctor, sir,
No,
in Oman?
no,
No. Okay.
no.
Okay, sir.
IM you can give. EpiPen is
Okay.
available in the market. EpiPen is available in the
Mm.
market. EpiPen is a intramuscular ready to use pen is available. You just need to give it into the lateral wall of thigh. That's it. That's it. Ready made. I was working in Oman, so I was using a lot in case of anaphylaxis or something goes wrong. EpiPen is available. All everything is there. It's a just ready to use pen, right? You just need to push it. That's it. You
Mm.
got it, right? So adrenaline is
Yes.
there. plus 0.5 milligram adult dose is there, right? Dilution is also perfect. You just need to just push it. That's it. It is popularly known as EpiPen, epinephrine pen. So it's like same pen, right? The what pen is here, right? So it contains the epinephrine, EpiPen. The name of the injection is EpiPen, epinephrine pen, right? You just need to just push from here, and it will go into the lateral wall of thigh. That's it, right?
Okay.
So
Yes,
that's all. Thank you very much. We gonna cover each and every topic properly in detail, right? Not in hurry. So this is one of the most high yield and frequently asked questions to every other students. I want and wish you to read again once again and try to come up with the more questions in the next class. I will now
Okay.
announce the more
yes.
class every other day. So try to prepare from our website. Everything is there only. Nothing new, right? If something
Okay.
comes out of the way, just write down. We'll discuss in the next class. Next class. All right.
Okay, sir. Thank you, sir.
Sure.
Thank you
Okay.
very
Thank
much.
you so much, sir. Thank you
See
so
you.
much.
Take care. Bye bye.